Dear colleagues, my name is George Sarris. I am a pediatric and congenital heart surgeon serving as director of the ECHSA Congenital Cardiac Database and chair of the ECHSA Database Committee. Today, I would like to briefly present to you an overview of the ECHSA Congenital Database and to demonstrate some of its most recent facilities serving its users. Specifically, I will summarize the unique artificial intelligence and machine learning derived tools which were developed in collaboration with the expert AI team of Professor Dimitris Bertsimas at MIT. These tools permit accurate, case-adjusted, and hospital-specific individual patient risk prediction, as well as objective congenital cardiac center performance for the purpose of center self-evaluation and quality improvement. Now, it is obvious that to evaluate surgical outcomes, one needs first to carefully measure the outcomes of interest, such as mortality or length of stay, or complications or other parameters. In other words, one needs to collect data in a database. As famous data scientists have very aptly stated, if you can't measure something, you cannot improve it. And of course, without data, you're just another person with an opinion. And we should keep in mind that for a useful database, it is necessary to start with a defined nomenclature for the data fields collected, a nomenclature accepted by all. There are other requirements which include the following: a suitable software platform, a mechanism for ensuring data veracity, accuracy, and completeness, a mechanism for risk stratification and risk adjustment, and finally, one needs useful analytical tools. Again, the ultimate goal for collecting data is to provide a basis for recommendations or actions following data analysis. The ECHSA Congenital Cardiac Database fulfills all of the requirements for a valuable congenital cardiac database which I just listed. With a history going back to the mid-90s, as detailed on the database's website, it has been dynamically growing over the years, and by now it contains detailed information on more than 350,000 procedures. The data within the ECHSA database are contributed by a large number of congenital cardiac centers participating voluntarily, mostly from Europe, but also from other continents. Very importantly, all the data in the database are anonymized, and there is independent certification of full compliance with GDPR data protection regulations. The periodically updated nomenclature, currently based on the International Pediatric Congenital Cardiac Code, ICD-11, as well as all the data fields collected, have been regularly harmonized with those of the STS Congenital Database in the United States, facilitating joint studies and cross-Atlantic scientific cooperation and comparison. There is also an ongoing data verification program to ensure data accuracy. Finally, and very unique to the ECHSA database, it offers multiple data analysis tools which are available on a 24-hour, 367 days a year basis directly online to the users. Importantly, the ECHSA database, in official partnership with the Association for European Pediatric and Congenital Cardiology, the AEPC, will now be enriched with interventional congenital cardiology data curated by the AEPC. The AEPC interventional part of the ECHSA Congenital Cardiac Database profits from all the analytical capabilities of the database and the large background of surgical data. This collaboration opens new horizons for the analysis of surgical and interventional treatments for our patients. This collaboration is a landmark, and it has been announced to the congenital cardiac community by simultaneous publication in both the World Journal for Pediatric and Congenital Heart Surgery, aimed at the surgical community, and in Cardiology in the Young. There are multiple reports available to the users online, as I mentioned, on a 24-hour basis. Many of these reports are standardized, and you can see a list of them on the left side of the slide. A unique feature of the ECHSA database is that it provides filtering tools which permit the user to examine data for self-defined patient subgroups selected by multiple factors or criteria, such as by age group, by diagnosis, procedure, or by specific risk factor, and so on. So the data of the selected cohort can then be analyzed by any classical medical statistical method one wishes to use. However, classical analytical methods such as linear regression have many shortcomings and limitations. They are susceptible to human bias. They assess predetermined relationships between possible risk factors and outcomes. They require time-consuming study for each separate question posed, and they cannot provide answers to questions that may not yet have been posed. This is the so-called black swan paradox. Finally, classical statistical methods assume very frequently linear and additive relationships existing between possible risk factors and outcomes, but this assumption is frequently entirely invalid. To circumvent these problems, an exciting pioneering addition to the data analytic capabilities provided by the ECHSA database has been developed, and this has been the introduction of artificial intelligence and machine learning tools. This has been the result of cooperation between the ECHSA database and the team of Professor Dimitris Bertsimas at MIT, Dimitris Bertsimas being a world expert on AI and its medical applications. Again, AI analytics were introduced despite the excellent track record of traditional medical statistics for many years, exactly because AI analytics provide multiple advantages which circumvent the limitations of classical statistics, which I just described. Specifically, the methodology is inherently nonlinear. Therefore, it is devoid of the false assumptions of risk factor linearity, which is inherent in traditional methods. AI methodology is less prone to bias, it is highly accurate, and it can reveal previously unappreciated relationships between risk factors and outcomes. The AI methodology is also extremely fast, and it is ideally suited to facilitate center self-evaluation and quality improvement initiatives, as I will demonstrate. The AI machine learning derived models using the optimal classification tree methodology that we have developed present themselves as decision trees. It is important to note that the models, namely the decision trees, are not black boxes, as perhaps some AI methods are known to be. The decision trees are easily understandable by us clinicians, so we can trust them. The models predict individual patient risk, whether it be mortality or length of stay or other parameters, with great accuracy, with AUCs of more than 0.85. And they assess center performance after congenital heart surgery in a hospital-specific and case mix adjusted manner. These techniques are detailed in publications from our group in major journals as listed below. Based on our AI methodology, we also developed an in-depth benchmarking tool which is available online. And this tool enables further and deeper self-analysis of one's hospital performance. Here is an example of the ECHSA Database AI and machine learning derived Congenital Heart Surgery Center Quality Report. Again, it's important to note that any participating center can log into the database with its own credentials and download its own confidential report whenever desired. Each center can only see its own confidential report, its own data, its own results, and of course cumulative anonymized data of the entire database using the filtering tools I described earlier. Now let's see the elements of such a center-owned report. For each of the outcome parameters selected, and here we have selected mortality, postoperative ventilation time, and length of stay, the observed risk is shown, as well as the expected risk and the difference between the two. So here we see the observed mortality, the expected mortality, the difference between the two, and the number of patients this involves. The color coding indicates whether any observed difference is statistically significant or not. If worse outcome observed versus expected is noted, then this is indicated with red color shading. If a better outcome than expected is observed, then this would be designated with a green color, not in this case. Otherwise, there is no color shading. So in this case, mortality observed is 3.8%, expected is less, 3.2%, but the difference of 0.5% is not statistically significant, and there is no color shading. Now the graphs here on the left side indicate where the center performance stands in comparison with all other centers as measured by the observed over expected ratio. The O to E ratio of 1 indicates expected performance. Greater than 1 indicates less than expected performance, but the statistics will show whether this is statistically significant or not, and the observed over expected performance less than 1 indicates better improved performance. The graphs on the right show the O to E ratio of all the centers versus a measure of the severity of the center's cases as measured in the x-axis by the EACTS-STS mortality score. The position of the center in question is shown by the crossing lines. So this report provides an overview of the center's performance regarding all cases analyzed together. In addition to the overall assessment of the performance of the center, looking at the average of all types of cases performed, the AI analytics also provide a detailed, further, deeper analysis of performance, which is summarized in this graphic, which we like to call an X-ray view of the performance of the center. So for the anonymous example hospital shown in the figure, the AI machine learning derived risk model for mortality presenting itself as a decision tree is shown on the left. This OCT model segments patients into 11 unique cohorts of similar risk. These cohorts are the terminal leaves of the tree, and they are colored, in this particular case, green, indicating better than expected performance, or no shading, indicating performance as expected. Now, for each cohort, this determination is made by comparing the observed outcome to the expected outcome of a matched cohort in the entire database. In other words, the analysis is both hospital-specific and patient-adjusted. For this particular hospital, the overall mortality is lower than expected, and this is represented by the green color in the first node. But if you note that the analysis of each unique cohort into subgroups reveals that there are subgroups of each cohort where the analysis may show either worse performance or better performance or performance which is average. In other words, each unique terminal leave, each unique patient cohort is further analyzed in subgroups, and in this particular case it is analyzed by or into the benchmark procedure groups, which are well known, and they include groups like coarctation repair, tetralogy Fallot repair, arterial switch operation, arterial switch VSD, Fontan, and so forth, as you can see in the table. Again, this analysis shows that although overall performance is better than expected, there are subcohorts of less than expected performance. So now, in addition to these static tables provided in the AI-derived quality report, which each user is free to download, an online tool has also been developed, which provides the user with the power, which is a friendly user power, to do these X-ray analysis by himself or herself. The short video that follows will demonstrate how this online platform works to provide instant center self-assessment using AI technology.
This online platform allows each European Congenital Heart Surgery Association database participating hospital to perform its own benchmarking analysis instantly. The platform is based on the optimal classification tree analysis. The user can select the outcome of interest, mortality, post-operative ventilation time, or length of stay. Here, we choose mortality. Also, we chose to analyze the benchmark procedures in greater detail. Here, the hospital code is selected. Each participating hospital only has access to its own data analysis. In this time frame window, we have selected to analyze the full span of data provided to the database. The analysis presents itself as a decision tree, the branches of which can be followed to the terminal leaves, which define unique cohorts of similar risk. Following the branches step by step makes the logic fully interpretable. At the top level, one sees the overall outcome. Observed mortality is 3.8%. Expected case-adjusted mortality is lower at 3.2%. However, the difference is not statistically significant, and this is indicated by the white color of this box. The decision tree leads to unique patient cohorts, the definition of which is immediately revealed with the cursor and is readily understandable by following following the decision tree path. It is clear that while the overall mortality is as expected, there are some patient cohorts with worse than expected mortality. These represent areas of opportunity to improve. There are also cohorts of better than expected performance. These results are further analyzed by benchmark procedures, providing what we call an X-ray view of the hospital performance. It is evident that for the arterial switch operation with VSD closure, the overall performance is less than expected. However, not across the board, but only in these particular subcohorts. It is also evident that in this hospital, whose performance is as expected on average, there are not only cohorts of opportunity to improve, but also cohorts of better than average performance, in particular for repair of VSD and for repair of tetralogy of Fallot. Another feature of the online platform, which is quite amazing, is that it allows the user to see trends and examine how these results have changed over time. You can move the slider and limit the analytic window to more recent years. As you do that, you can see that the results are instantly calculated. If you stop here, you only have a 2-year window. In fact, you can fix this time window and then look at the data, how they change over time in 2-year increments. You can see that there was a period where there were many areas of opportunity to improve, and more recently, the results are quite on par with average, except for a couple of minor cohorts. This online platform allows each European congenital heart surgery.
Dear colleagues, if you wish to participate in the ECHSA Congenital Cardiac Database, it is a simple 1, 2, 3 process. All you have to do is visit the website, click on the link joining the database, and just follow the on-screen instructions. If you need more help, please either visit our website, contact Dr. Zdzislav Tobota, who is the ECHSA Database Technical Director, for any help with the process of signing up for software support, or just contact me directly. Thank you very much for your attention.